The unit of the urinary system, the nephron, carries out two main functions. One, filtration of the blood at the glomerular level, as it is estimated in inverse proportion by serum creatinine level. And two, reabsorption of the filtrated fluids and solutes, as they are estimated according to what is found at the urine level over 24 hours, chemical and microscopic urine analysis, solutes estimation, etc. And, in the meantime, what is missing in the blood owing to losses, electrolytes, hydrogens, ions, pH, albumin, amino acids, etc. Urinary tract disorders can be summarized in 5 main syndromes, namely 1. A decrease of the filtration capacity up to the acute or progressive renal failure. 2. Irreversible or chronic renal failure. 3. Nephrotic syndrome. 4. Tubular defects, chiefly involving the reabsorbing function. And 5. Urinary tract infections. The main causes of filtration impairment are 3, namely A. Pre-renal causes, that's what may happen before the afferent arteriole, extremely important to diagnose quickly because may be reversible. B. Intrinsic renal causes, from the glomeruli to the calyces. And C. Post-renal, from the pelvis down to ureters, bladder, and urethra. The table guides the clinician to a practical differential diagnosis. Chemical and macroscopical urine analysis, serum creatinine, urea, electrolytes, including sodium, potassium, calcium, and phosphates, are the basic tests to be carried out in order to address the 5 main urinary system syndromes. The ultrasound scanning machine, even Palmer, at the patient's bedside, provides quick diagnostic completion by exploring the morphology of kidneys, bladder, prostate, seminal vesicles. The color Doppler mode and the continuous wave Doppler support the differential diagnosis of a kidney blood flow. The morphology of the blood vessels in the fundus oculi is consistent with the one in the kidneys. Normal weight, the patient was hypertensive under therapy with converting enzyme antagonists. A long-standing proteinuria appeared to have been worsening lately. Although no edemas were observed yet, the diagnosis process moved through 4 steps. The first one was made up of a set of laboratory tests to address the hypothesis of nephrotic syndrome against nephrangioschlerosis as a complication of malignant hypertension, despite the treatment. The proteinuria came up not to be selective, as being made up of albumin, immunoglobulins, free light chains in mild concentration. Monoclonal gammopathies and mellitus diabetes cause microvascular damage were ruled out. Concurrent low serum albumin, hypercholesterolemia, and mildly increasing serum creatinine brought to the conclusion of nephrotic syndrome. Further evidences of diffuse glomerular damage came from the second step, namely the imaging tests such as A. Echo Doppler. Both kidneys were osmolicized than normal, being the right one of 8.4 and the left one 9.6 centimeters length. B. Continuous wave Doppler over the right renal artery, high velocity flow and high resistance with no diastolic flow. C. Magnetic resonance imaging, preferred to the contrast computed tomography scan, because of the mild renal failure, showing 2 renal arteries in the right side, but no stenosis and a good total flow. Step number 3 focused on autoimmune diseases as a pathogenetic source of glomerular damage. Actually, the fraction C3 of the complement system was found to be decreased, but the absence of circulating autoantibodies ruled out all the major autoimmune diseases such as lupus erythematosus, rheumatoid arthritis, vasculitis, progressive systemic sclerosis, etc. Inevitably, the last step was the renal biopsy. 1/3 of the glomeruli were already sclerotic or even hyalinized. and therefore definitively lost. Most of the remaining ones show the basic lesions of the focal segmental glomerulosclerosis histological pattern. Unfortunately, it is well known that such a disease would proceed to chronic renal failure unless treated with high doses of steroids and other immunosuppressive drugs. In such a perspective, at first, the patient was vaccinated against COVID-19, common flu, Haemophilus influenzae, and meningococcus. To set up the differential diagnosis diagram and thereafter, to select the diagnostic test accurately while challenging the crux step by step. Recurring events of urinary stones since teenage. The chemical analysis had detected cystine urinary stones. Actually, a 30-year-old urine analysis report confirmed an ever-standing presence of a high amount of cystine crystals. The syndrome was framed as a congenital renal tubular defect in amino acids reabsorption. The chromatographic test on plasma and urinary amino acids confirmed a high amount in the urines and consequently low amount in the plasma of cystine, and the two basic amino acids lysine and arginine. The acid-base balance was unaffected, as from a blood gas analysis test. Later, in his youth, pain to the backbone encouraged the patient to undergo computer tomography and magnetic resonance imaging tests. The vertebrae appeared as osteoporotic and barely calcified, to be better assessed by bone biopsy, with previous administration of tetracycline as a marker of new bone apposition. The histological pattern highlighted: A. Fewer trabecular, but thicker than expected. B. A scarce amount of osteoid tissue as an evidence of low turnover. C. Main spot of fibrosis. And D. Normal bone reabsorption. In conclusion, the apposition of new bone was strongly impaired. The poor availability of the three above-mentioned amino acids supposedly caused such a histological pattern. The treatment addressed: A. The permanent alkalization of urines to prevent the high amount of cystine crystals from precipitating and turning into obstructing urinary stones. And B. To replenish the missing amino acids with an additional intake to speed up the apposition of new bone. Whenever healing is not possible, to minimize complications and preserve the renal filtration capacity. The diagnosis of type 2 mellitus diabetes, hypertension, hyperuricemia, and thalassemia microcytonemia were already established and properly treated by metformin, sartans, calcium antagonists, lercanidipine, allopurinol. Over the past weeks, the syndrome was made up of bilateral pedal edemas, increase of serum creatinine from 1.2 up to 1.8 milligrams deciliter, unexpected decrease of hemoglobin levels from 12 to 8.9 grams per deciliter. No proteinuria and low serum albumin were evident to sustain the hypothesis of dyscrasic edemas and/or other intrinsic renal causes of renal failure. During the physical examination, there was spotted hypertension, 105/60, with no compensatory tachycardia, and systole-diastolic heart murmur over the aortic valve. The heart murmur was apparently of recent onset. Therefore, the dissecting aneurysm of the aorta was investigated immediately. The normal ankle brachial index and the echocolor Doppler of the aorta from the aortic valve down to the iliac bifurcation ruled out any dissection. Afterwards, the differential diagnosis of the impaired renal filtration focused on prerenal causes, and the continuous weight Doppler performed from the renal arteries upstreaming enabled to build up complete hemodynamic figures. The total flow per minute to the kidneys was decreased to around 450 milliliters per minute, far less than the 1000 milliliters expected. The stroke volume was low at 42 milliliters and worsened by 28% of aortic valve regurgitation. The low stroke volume and heart rate below 65 at rest gave evidence of a strongly decreased cardiac output. In addition, the preload was decreased since the systemic venous system was at low pressure, as was shown by the inferior cava vein collapsing completely during inhalation. Thus, hypovolemia and the chain of factors had supposedly driven the deterioration of the renal filtration. The fact that anemia had also worsened was the clue that an unrecognized blood loss had occurred from the gut. Furthermore, when investigated purposely later, no blood loss was evident from the feces. However, the patient's parameters, serum creatinine, hemoglobin, blood pressure, had been recovering spontaneously within 1 month's time. Renal physiology is strictly connected with the cardiovascular system. In acute renal failure, to address the life-threatening differential diagnosis, aorta dissection for first. Mellitus diabetes type 2 in successful treatment with metformin 500 mg 3 times per day. In 2004 to 2006, the patient suffered successive episodes of bilateral renal colics. At that time, radionuclide and imaging tests assessed the morphology and function of both kidneys as normal. During one of these occurrences, the X-ray obstructing opaque urinary stone was detected in the right ureter. The urologist proposed inserting a stent to ensure proper urine outflow, but the patient refused. In 2019, the patient had a mild fever, burning pain in the urethra, and discomfort in the hypogastrium during urination. The general practitioner prompted the diagnosis of cystitis and treated the patient with the antibiotic ciprofloxacin successfully. Later, in a periodical medical checkup, an ultrasound scan reported the right kidney to be much smaller than the left one, 8 centimeters of length against 14. The glomerular filtrate was estimated at 53 milliliters per minute. The metabolism of calcium and phosphate was normal. The urine emitted was sterile upon doing a bacterial culture, and upon microscopic examination of the sediment, some red blood cells, few leukocytes, and plenty of oxalate crystals were visible. The computer tomography scan confirmed the atrophy of the right kidney, and no flow iodine contrast was detected along the right urethra. A slight dilatation of the right pelvis and 2 X-ray opaque small urinary stones were detected in the lower calyces. The left kidney was intact. Final diagnosis determined atrophy of the right kidney caused by chronic pyelonephritis. The functions of the right kidneys were irreversibly lost and partly compensated by the left kidney. The therapeutic strategy addressed the preservation of the health of the left kidney by 1. Ruling out any reflux from bladder back to urethra, which could bring ascending infection to the left kidney. That information was obtained by means of avoiding cystourethropography test. 2. Alkalizing the urines by persistent intake of potassium citrate to prevent oxalate crystals from precipitating. 3. Diet poor of oxalate. 4. Drinking a minimum of 2 liters of water per day. The urinary tract obstructing stones are a serious matter not to be underestimated for long-term consequences. Normal weight. Congenitally single left kidney with single renal artery. 3 surgeries for bladder ureteroplasty, but unfortunately no surgery reports were available. Type 2 mellitus diabetes. According to the high levels of glycated hemoglobin, the diabetes was held in decompensation despite the recent intake of the glycosuric drug dapagliflozin. After such a change in treatment, the serum creatinine increased from 1.6 to 1.9 milligrams per deciliter. Definitely, some decrease of the glomerular filtration was occurring. Consequently, the differential diagnosis was drawn up as in the diagram. 1. Pre-renal causes either A. Stenosis of the unique renal artery or B. Hypovolemia due to dapagliflozin. 2. Intrinsic renal causes due to infectious pyelonephritis. 3. Post-renal causes due to recurring obstruction of the final tract of the ureter. A computer tomography scan ruled out both the renal artery stenosis and the post-renal obstruction at the pelvis and ureter level, although some dilatation of the third distal of the ureter was visible following the surgeries. The chemical and microscopical urine tests showed no pyelonephritis pattern, no leukocytes, no casts, etc. And the microbiological culture was negative as well. It was concluded that dapagliflozin caused reversible increase of serum creatinine. Although the literature reports that such an increase is self-limiting, the decision was made to discontinue such a drug and switch to semaglutide. In chronic multidisciplinary patients taking several drugs, the cardiovascular renal balance may be broken unexpectedly. The patient, who had been living in Northern Africa for a long time, had recurrences of moderate fever, 38.5, moderate abdominal pain with no abdominal defense, minimal alterations of bowel movements, minimal neutrophilia, mild proteinuria and hematuria, and high serum C-reactive protein. During the computer tomography scan, some thickening of the mesentery was spotted by the radiologist. In any of such events, the patient was admitted to the hospital where he had been recovering slowly with various antibiotic treatments or even spontaneously. Upon the fourth recurrence in 6 months and with no diagnosis established, a second opinion was requested. By reviewing the computed tomography scan, both the adrenal glands were enlarged. Both kidneys were affected by perinephritis. An X-ray hypodense and inhomogeneously edged lump was spotted in the superior pole of the left kidney. The lump was mildly enhanced by the iodine contrast. Either kidney showed wedge-shaped large hypodense portions of the parenchyma involving cortex and medulla. Several calcific spots were discovered in the genitourinary tract, prostate, seminal vesicles, spermatic cord. Micronodules and interstitial thickening were seen in both the lower lobes of the lungs, in continuity with the visceral pleurus. Fibrotic adhesions were filling both pleural cavities at the lung bases. The overall clinical picture matched a systemic disease made up of periodic bacteremic waves followed by the implantation of bacterial spots in the genitourinary system, lungs, pleurus, and probably mesentery. Mycobacterium tuberculosis was searched for in the urine, albeit unsuccessfully. The quantiferon test on patients' CD4 lymphocytes returned uncertain. However, the strong imaging evidences suggested to implement an ex juvantibus treatment with rifampicin for 3 months first and thereafter extended to 6 months. No symptom complex recurred for the following 3 years. Low-grade recurring fever may still be due to tuberculosis, and the urinary tract is often affected. If diagnosis is not ascertained, the ex juvantibus treatment is still helpful. Normal weight, despite age, good cognitive and physical conditions. For 20 years, the patient demonstrated chronic atrial fibrillation with a heart rate of around 75, with one occurrence of acute heart failure and pulmonary edema. In the therapeutic package, high doses of furosemide, 37 mg in the morning and 25 in the afternoon, were spotted. The blood pressure was kept as low as 100/70. Over the last 3 years, the patient underwent 2 transurethral bladder resection for high-grade bladder carcinoma. In routine biochemical tests, the serum creatinine increased from 1.1 to 2.1 milligrams per deciliter, and potassium was borderline to high at 5 milliequivalents per liter. Thus, a decrease in renal filtration capacity was occurring, and the general practitioner requested a renal ultrasound scan of the kidneys. The right kidney was mildly small-sized, 8.5 centimeters long, with a 9 millimeters thick cortex. The left kidney was normal. The general practitioner concluded at senile nephrosclerosis, hinting that the impairment of renal filtration had to be held as chronic and irreversible. Upon a second opinion consultation, the intrinsic renal causes were ruled out since no abnormalities were spotted in the urine analysis. Because of old age and the clinical history, the differential diagnosis diagram focused on 1. Pre-renal causes, such as either iatrogenic low blood pressure or bilateral renal artery stenosis, and 2. Post-renal causes, such as obstruction of both the bladder ureteral meatrices due to recurrent bladder carcinoma. A second ultrasound scan focused on such a differential diagnosis. The bladder was deformed due to the previous resections, but no recurrence of bladder carcinoma was detected inside. By color Doppler ultrasound scanning, the flow from both ureteral meatrices was spotted, and therefore post-renal obstructions were ruled out definitively. Both renal arteries were examined, and a continuous wave Doppler test applied on the left renal artery. The flow was normally triphasic, with a maximum velocity of 50 centimeters per second and a clear diastolic flow visible. Therefore, the flow downstream was not resistant, as would be expected in nephrosclerosis. Out of these assumptions, the diagnosis was of impaired renal filtration due to iatrogenic low blood pressure. The furosemide intake was reduced to 25 milligrams per day. The blood pressure quickly increased to 125/75, and the serum creatinine decreased to 1.5 milligrams per deciliter within 1 week's time. In elderly patients, to check and reconcile therapies frequently, some drugs in high doses may be unnecessary or even dangerous.